Hey, welcome back to another epidose of these crazy people who just eat meat all the time and can't stop talking about it. Today, we have a very special guest. I'm very honored to have Dr. Paul Mason all the way from down under. Thanks, Joe, for making it happen. And I'm sure a lot of people out there already know who he is, or who we are. So, but why don't you say hello real quick, and why don't you tell us a little bit about your Low Carb All Stars 2020 to get things going?
G'day. So, yeah, I'm from Sydney in Australia. I'm actually a medical doctor. And unlike most doctors, I'm not vociferously opposed to animal-based diets. I think animal foods are inherently healthy and nutrient-dense. So I feel like I'm in a bit of a like-minded crowd here. So it's a really nice feeling, albeit remotely. Yeah, just as you alluded, just a couple of weeks back, we ran a online low-carb conference, mainly because all the physical conferences are now being thrown out because of this little epidemic that's come our way. And yeah, we are absolutely blessed with a huge response from the doyens of the low-carb world. So, you know, I won't name everybody, but we had, you know, pretty much all the big names who were very generous in providing us with very excellent content. We ended up with a wee bit much, actually. We ended up with, you know, over 11 hours of content, which made for a full day. But fortunately, everything was recorded, so it'll eventually be available on playback on YouTube. But for the moment, for all the conference subscribers, all that content is still available for review. And hopefully over the next 12 months or so, it'll be drip fed onto YouTube.
Yeah, there was lots of great content, lots of great slides from a lot of the usual suspects. I know Ivor Cummins was in there, and Dr. Ken Berry, and Dr. Unwin, and Dr. Lustig, and Ben Bickman, and on and on and on. And they all brought new stuff to the table.
Tim Noakes, Thomas Seafried, Sarah Hallberg. Yeah. You know, it was really an all-star cast.
Yeah,
absolutely.
Dream come true for us science nerds too.
And representing carnivore, Amber O'Hearn, of course, and Paul Saladino. So that was a really nice treat.
Yes.
Yeah, well, I mean, representing carnivore, or, you know, just on the side of science. You know, however you want to look at it.
There you go.
Exactly.
Very true.
Yeah, we tend to look at the whole kind of low carb umbrella as sort of one crowd. You know, us here definitely distinguish ourselves as carnivores because we pretty much just eat meat, because we tend to have problems when we eat plant-based foods. But it's not like any one of us is convinced we need to go tell everybody else they should only eat meat. You know, I think we all sort of have an individual tolerance for different things, right? So,
well, I think that's absolutely the case. And, you know, it's true that there is a lack of research on the carnivore diet. Now, there's a lot of research that's absolutely being ignored, but a lot of the evidence would have to argue is anecdotal and N of one. But every one of you guys here is an N of one advocate for a carnivore diet based on a profound experience. And funnily enough, I see that in my clinic every day.
Yeah, I'm not too surprised that you do. It's good that you're down there, and it's good that you're part of generating all this content, because I mean, you reach a very broad audience, you know, because obviously I don't know anybody who follows the movement here who doesn't know who you are, who hasn't watched your lectures. So,
oh, thank you.
Yeah, I try to put things in perspective because I live in California, and there's more people in California than there is in Canada. And there's more people in Canada than there is in all of Australia. So, you know, even though you're on a huge continent, you're a small population down there, but you're a very potent population as far as the world goes.
Well, in terms of low carb, I mean, I think that truly we do punch above our weight when I have a look at the number of people we've got with your Gary Fetkes of the world, who's a trailblazer, your Peter Bruckner, you know, low carb down under, being headed by Rod Taylor, I think has been a worldwide force in low carb. So I guess I'm sort of privileged to be surrounded by a lot of like-minded folk, and certainly I'm on some Facebook groups of low carb and paleo doctors, and that's got well over 1,000 members on it. from within the region of Australia. So there's certainly a lot of support. A lot of people are doing it personally. A lot of these doctors are probably not quite brave enough to introduce it as a mainstream practice. But the fact that they're getting such strong personal benefits, I think the trend is clear.
Yeah, well, I'll say for my second to last doctor, I asked him about, you know, should you eat different kinds of food or whatever, or different kinds of foods better for one person or another? And he kind of gave me the answer like, no, it's really just about how many calories you eat. That's really all he had to say. And I fired that doctor and I got another doctor. And that doctor, when I told him what I was doing, he was actually very curious, and I was kind of prepared to say, well, I don't expect you to endorse what I'm doing, but you know, I'd like some cooperation, maybe sign off on some tests and stuff like that. And he was more than happy to do it. And I've actually taken books to him to read, and he's actually enjoyed reading them. I don't talk to him very often, but there are doctors out there who are willing to at least talk about it behind closed doors. So hopefully more of them will come out from behind the closed doors like yourself.
And funnily enough, there's doctors will, for want of a better word, tolerate it.
Yes.
So I get referrals from other doctors all the time who, if you ask them, are saturated fats good? They would be unequivocally say no. And yet they still send me patients. And I'll often ask them, I say, so did your doctor tell you what to expect when you came here? They said, no, didn't say anything. They don't want to talk about what you do, but they're happy with the results you get. And I'm happy with that. You know, that's a step towards progress.
Isn't there a legal danger to that as far as the dietitians of Australia, for example, for advising more of a meat-based diet?
Oh, traditionally, there certainly has been. I mean, we've got dietitians being deregistered. We've got AHPRA, which is a medical registration body, you know, trying to attack Gary Fettke. There's certainly been issues with that. But I think now that's backfired in their face. If you have a look at what happened when the mainstream establishment, you know, which was really underwritten by industry, tried to take out Tim Noakes at the knees, I think that's really backfired on them, and it's just really brought more attention to it. And elevated Tim's profile even more. So I think they're going to be a wee bit cautious. And the fact is, we're strongly supported by the literature. So just 6 days ago, there was a piece by David Diamond and Asim Malhotra and a few other authors in BMJ Evidence, British Medical Journal, one of the world's leading medical journals. And it was referencing the dietary guidelines that we provide for people with extreme cholesterol levels, what would often be diagnosed as familial hyperlipidemia or familial hypercholesterolemia, cholesterol levels that we often see in a subset of people on strict ketogenic diets. And they basically, the crux of it was there's no evidence to support reducing dietary cholesterol or saturated fat. And instead, our target should be looking at carbohydrates, triglycerides, markers of insulin resistance. So this kind of paper coming out in a top tier journal provides somebody like me with a degree of protection so if I have a patient with very high cholesterol levels, I'll do all the usual risk assessments. You know, you listen to the heart, you check the blood pressure, you probably do a coronary artery calcium score. But at the end of the day, when it comes down to the intervention, if we do decide there is an elevated degree of risk, I am now supported by the literature in terms of recommending low carbohydrate style diets. And I think it would be very hard for a body to come after me when I've got such recent contemporary top level evidence on my side.
Yeah.
They still might try. Who knows what will happen, but you know.
So I'm kind of curious about that, Dr. Paul Mason. When did a light bulb go off in your head that, like, wait a second, what they're teaching us in the schools and everything is kind of bunk or garbage?
Do you remember Robert Lustig's talk, Sugar, the Bitter Truth? It's about 10 years old now.
Yes.
So it was about that time, and I usually tell the story that it was sort of reading an editorial in the British Journal of Sports Medicine, but it was about this time, and it was probably a compound effect of both this talk, that would have been, about 10 years ago, thereabouts, and an article in the British Journal of Sports Medicine by Professor Timothy Noakes and Professor Peter Bruckner. And the combined effect was I was looking at it going, no, this can't be right. But looking at the references in the article, looking at the science that Rob Lustig presented, it was a near 2-hour lecture. It was, it was not something that you sit down and idly watch. I was like, maybe this stuff I learned in medical school isn't all it's cracked up to be. And that sort of really started my journey. And I experimented on myself and then had great results. So then it evolved into a logical thing that, if you have started with, I remember I was on a rotation. I had a young lady bring her children in, and the children were sitting there drinking what you guys would call sodas, 600 mils. And that's a lot of sugar for little kids. And I just pointed at them and said, they are so not healthy. I said, this is what they're doing. And she looked at me with this look of gratitude. She goes, thank God, this is what I'd feared, but nobody had ever given her the explicit permission to the instruction. So she looked at her kids and said, throw them in the bin right now.
Wow.
They were in the bin. And she said, I'm never buying them for you again. And that's, back then, that was controversial. And then I'm saying the same goes for fruit juice. Back then, this is fairly recent history, but to say that sugar was doing the damage, I mean, we had these studies coming out, or from Sydney University, what we call the Australian paradox, saying sugar's not the problem. It's very recent history that scientists were making a concerted effort to actually take sugar off the hook for what it's doing. So I guess it started with the sugar, and then it morphs into, well, if sugar's bad, complex carbohydrates are really just polymers of glucose molecules. That probably can't be so good either. And you dig deeper, and then you go, well, seed oils don't seem to have such a good rap either. And then you look at it and say, well, what about fiber? Do we need fiber? And you look at the evidence, like, not so much. And then they're like, well, what about salt? We're told we should reduce salt. And it's like, yeah, actually, no. And then more recently, you look at something like trans fats, because we all know that trans fats is bad for us, right? Actually, when you look at the literature, it's not that clear cut. And we all know that olive oil is good for you. Again, you look at the literature, not clearly shown. So basically, every edifice on which our dietary advice has been built, which I have over the last 10 years, it's been a bit of a journey that I've actually taken a close look at. You just see it sort of crumble. I'm like, well, what are we left with? And I guess it's what we're left with is an evolutionarily appropriate diet.
Do you think we'll get to the point in our lifetimes when the average doctor will tell people that sugar or excessive carbohydrates actually causes type 2 diabetes?
Yes, but probably not for another 20 years.
So my lifetime, not necessarily yours, Tom.
See how this is going.
Well, I was shocked because my psychiatrist, he's watched me. He's been my psychiatrist for 8 years. So he's watched me through the worst of the worst when I was cray-cray. Like totally I was on 900 milligrams of lithium, 80 milligrams of Prozac, 80 milligrams of Adderall just to get out of bed every day. And I was still not functioning. I was still struggling. And so he watched me through the bad. And then he watched me just completely resolve all of this and start working full time and being able to function. And he even said to me, he's like, there's light in your eyes. And then he was the one who said, okay, let's start tapering you off of some of this. And I wasn't ready. I was like, no, that's my security blanket, but we did, and we tapered off. And I haven't had psych meds since, I haven't had any meds since September 26th of 2019. And I have been able to stay out of the psych ward. I have been able to work. I've been able to be fine and stable throughout, life. It still happens. But this last session that I had with my psychiatrist, because I still see him just because I want to make sure I'm still on target. And I still see him even though I don't take any meds. And he said, I got to tell you something. And I was like, what? And he was like, I was eating oatmeal and bananas for breakfast and I thought it was really healthy. And then I decided to have bacon and eggs and I feel so much better. And I was like, cool. Even if you don't like recommend this to your clients or your patients, at least you're trying, this experiment out for yourself. So that baffled me.
The exciting thing about this is we've actually got good evidence of how diet actually impacts on mood. And I mean, we take somebody who has a diagnosis of bipolar, and we say, and we pathologize it. But the question is it really a problem of the brain, which we're defining it as, or is it just really a problem of a bad diet on an otherwise normal brain?
An inflammation.
And if we can take away the issue, as you've seen, a lot of it just resolves. So the way it works is you've got your brain, you've got all your brain cells, and we call them synapses, and they sort of connect, together. And then, but you need chemicals to communicate between the different neurons. We call them neurotransmitters. And if you don't have neurotransmitters, your brain's not going to function. Now, we know that certain diets lead to impaired production of neurotransmitters. So if you have a look at a vegan diet, things like B12 and zinc, they're essential for neurotransmitter synthesis. By the way, it's been shown, as you know, Tom, B12 is beneficial in some cases of autism. Why? Because probably these people are neurotransmitter deficient. Basically, any disorder involving the brain function is likely to involve neurotransmitters in some respect. So we've got the absolute nutrient deficiencies, but then, as you say, we've got the inflammation. And what a lot of people don't realize is that the inflamed state actually locks away essential nutrients in the body which are needed to synthesize these neurotransmitters. So you would have heard of iron. And this is evolutionary. So when we've evolved with infections in our environment. So every so often we get an infection, our immune system reacts to that, we get rid of the infection, then we get over it. Now, I don't know if any of you guys have ever noted that when you get a virus or a bacterial infection, for that period of time, you often have a period of depression. This is well known, depression associated with acute illness, that your mood just isn't as good. But nobody talks about why. And the reason is that we've evolved with infections, and pathogens, as a rule, need iron to survive. So our body says, well, if I lock my iron away in a vault, then it's going to make it easier for my immune system to eradicate this infection. So it does that. It locks the iron away in a vault. And the storage form of iron in our body is ferritin. So when you get inflamed, the amount of iron in your ferritin will actually increase and increase and increase because your body's not able to use it. And so a doctor will look at that and say, oh, your iron levels are fantastic. But it's actually totally not reflecting the reality, which is you've got the iron there, but you can't use it. It's starvation in a land of plenty. So what does locking this iron away do when you have an infection? It's only a week. You get over the infection, the inflammation goes down, you release the iron, you're good again. But what happens if you have an autoimmune disease that we haven't evolved with? You get inflammation from that, and the body gets tricked, and it thinks, okay, I'm inflamed, I must have an infection, so it locks the iron away. But this autoimmune disease can persist for months at a time, even years at a time. So you end up with a prolonged period where your body doesn't have access to iron. Your ferritin stores are very high, but you don't have it. So then what happens? Well, iron is a cofactor in the synthesis of catecholamines. These chemicals like dopamine and serotonin directly require the availability of iron in the body to be produced. So if you have chronic inflammation, through this mechanism of what we call iron sequestration, it means you end up becoming neurotransmitter deficient.
Wow.
And that explains why if we have an autoimmune disease, an inflammatory trigger, we treat the inflammation, the mood gets better. It's all about neurotransmitter availability. You need zinc, you need B12, you need all the nutrients, and then you also need not to be inflamed. And this is probably the biggest insight I've had in the last couple of years about health, is that I had such a big focus on metabolic health, being all about what your blood sugar is doing, so on and so forth. But I didn't have enough appreciation that when I treated the metabolic issue, there's a lot of people that still had these low-grade levels of inflammation that were clearly not normal. And usually, if it's not an infectious cause or a metabolic cause of inflammation, assuming cancer is not an issue, then almost certainly it's going to be an autoimmune cause. And these people with this inflammation and mood disturbance, gut issues, they're the ones who really respond well to the elimination diets. You know, the things that essentially what you guys are on elimination diets.
Right.
Just a question, going back to mood. Do you think there would be, now we talk low carb, but remove all your sugars. Would you say a higher fat, low carb diet would be better than a higher protein as far as mood?
Depends on how low fat. Fat is an essential nutrient.
Low carb. Sorry. So
say that again.
Okay. A higher fat content in your diet compared to a higher protein. So
you're talking about, Joe, after cutting the carbs, right?
Yeah, after you cut the carbs.
So fat is an essential nutrient for the brain. The brain is made an enormous amount of fat, but the fat doesn't just magically make the brain. It actually gets produced into ketones first, and the ketones then go into the brain. But you do having a certain amount of fat in the diet, I believe, is necessary. And it's also, fat is an essential nutrient. So if you go on an extreme low-fat diet, it's very likely that you'll impact on parts of the immune system, like the insulation called myelin around nerves. Those kind of things will certainly be impacted. So I certainly believe that if you, from a nutrient perspective, a fat-deficient diet is absolutely going to be a bad thing. And then we come to people who have certain issues with their, with the function of their brain. And I believe that in those people, running a higher ketone level appears to be beneficial. So we see it in people with dementia, Alzheimer's disease, probably also in people with autism. We see it in some people with epilepsy. They tend to they don't have to be as extreme ketone levels as what we used to recommend. In actual fact, we're now seeing that a modified Atkins diet can be, probably just as beneficial for epilepsy as the traditional, eat mainly fat with a trace of protein kind of diet. Mm-hmm. But I do believe that if you do have some issue with the structure of the brain, perhaps we'll talk a little bit about autism in a while, how gestational diabetes appears to be a significant risk factor for that. No doubt that does lead to a bit of structural alteration in the brain. Running higher ketone levels seems to be able to compensate for that. And you only get those higher ketone levels in a much higher fat diet. So for people who have Alzheimer's disease, they may very well benefit from much more fat in the diet. Whereas for somebody who doesn't have those kind of issues, running a diet with more moderate fat and higher in protein is probably optimal for them from a holistic perspective. But for the brain, occasionally, I'll recommend supplements that will be designed to increase ketones. Whereas for somebody with weight loss, I would absolutely steer clear of medium chain triglycerides and ketone esters and these kind of things. But in some occasions, if it's we're trying to get more ketones to the brain, and let's face it, ketones are the preferred substrate by the brain, you will get more benefit. So that's a bit of a roundabout way of answering it. It really depends. If your brain operates better on ketones, and a lot of people do, especially with mental illness and those kind of issues, or structural issues, say chronic traumatic encephalopathy, where you get, repeated concussions can cause that, then high ketones all the way, more fat. If you don't have those issues, then, you can probably be much more moderate on the fat.
Now, fasting also increases the ketones, right? I don't understand that portion of it.
So one of the problems is that we get confused between the ketones in the blood and the ketones that your body's using. So one of the reasons that fasting increases ketones is because it's impairing the utilization of the ketones, which I don't think is entirely productive. And the reason for this, it's a little bit tricky, but basically we've got the citric acid cycle. And all energy, acetyl-CoA comes in there, and acetyl-CoA can come from fat metabolism, that can come from the glucose side of it, the carbohydrate side of it, and that will then combine with oxaloacetate. And it requires oxaloacetate for this acetyl-CoA to then generate energy in the citric acid cycle. Now, the problem is, on a very, very low carbohydrate diet, or a fasting, when you're fasting, your oxaloacetate is diverted into something called gluconeogenesis, because you still need to make glucose. And oxaloacetate is one of them, a good substrate for gluconeogenesis. So you end up with a deficiency of oxaloacetate, which means that you're burning all of this fat, creating all of this acetyl-CoA, and it's coming to the doorway of the citric acid cycle and saying, okay, right, where's the oxaloacetate to let me in? And it's saying, hey, so I've had something else to do. Sorry, buddy, you're on your own there. So acetyl-CoA is building up. It's like, I can't produce energy. So then it gets diverted down another pathway, which eventually produces ketones. So in a way, this is indicating that you're burning fat, but you're not able to make use of the products of it. So you end up producing a load of ketones in its place. So I'm very conscious that people on very low protein diets, and fasting is probably as low as you can get, obviously, that can actually lead to an increase in serum ketones, but it doesn't necessarily reflect tissue utilization of energy. And we certainly see this in athletes, where a lot of the original research was really trying to encourage people to have incredibly high levels of ketones, ignoring the fact that by getting these high levels of ketones, they're basically impairing their body's ability to use the acetyl-CoA effectively. So that would impair their efficiency. So I actually think the optimal, say for athletic performance, as an aside, I think an optimal level of ketones is probably 0.3 to 0.5 millimoles a liter, which is well below the 1.5, even higher that a lot of people used to strive for.
Well, I think historically we came to the ketogenic diet backwards, right? Because they're originally looking for a diet that mimicked fasting, because they knew that people had seizures or psychotic behavior. They tended to improve when they starved them, right? So they're like, hey, what diet would mimic this behavior, what this improvement? And they're like, oh, they stumble into the ketogenic diet, when in reality, what we really need was a diet that mimicked a high fat diet. But and I think to some extent it's kind of circumvented adequate protein. So I think that obviously the protein demand on an individual is going to vary, but I don't think you can go more than about 24 hours without protein and not risk losing muscle mass, which I think is kind of proved to be one of the most protective things you could do for your body, long term, is to preserve as much muscle mass as possible, right?
I could not agree more. So whenever we look at metrics of longevity, things that are strength-based come in hugely important. How quickly can you get up from a chair and walk? What's your grip strength? How many push-ups can you do? These kind of things are hugely predictive of longevity, and the thing they have in common is they're all based on lean muscle mass. And as you get older, I actually I had a patient just yesterday, and they were just over 70, telling about the fasting they were doing, and I said, stop. I said, you're a stage of life. We want you in an anabolic state where you're building tissue. I don't want these regular periods of catabolism where your bone is being, weakened, where your muscles are wasting, just to, for this, mythical creature of mitochondrial autophagy and all these kind of things. And my belief is that if you exercise well and maintain a ketogenic diet, I think all the benefits that people talk about of recycling and autophagy, I think you can get them from fasting and exercise, from keto and exercise. I don't believe you need a prolonged fast. Now, having said that, I will make the caveat that what I call eating normally is what a lot of other people would consider to be fasting. Because if you only eat when you're hungry, I usually eat maybe twice a day, right? Some of my patients will only eat once a day. Now, and if you're only eating when you're hungry, I don't consider that fasting, because that's not volitional restriction. Whereas if I tell people, hey, I never eat lunch because I always work through lunch, I just don't take a lunch break. People say, well, you're fasting every day. It's like, well, I'm not hungry. Is that really a fast? So we've normalized this overconsumption of food.
Yeah, I'm a big believer in changing the language, and I like to borrow some. I know you've met Sean Baker before, and he likes to call it intermittent feasting. So he likes to eat when he's hungry and eat a lot, but not think of it as fasting because he's not intentionally going hungry, right? And
Exactly.
I think making changes like that to the language really is going to help people have a better understanding.
A volitional restriction of eating is what I would consider to be a fast. And if you're not consciously aware, if you're not going hungry, that's not a fast. That's just eating when you're hungry.
Yeah, and I'm the first one to admit that, you know, fasting occasionally probably won't do any harm. Of course, it depends on how long you fast, but you know, so people do it, you know, seasonally or annually for reasons, and maybe that is beneficial. But I think like we were saying, that maintaining lean muscle mass is probably the most important thing you can do. But second to that is you got to regenerate your joints, right? Because your joints break down just like your muscles. Anybody who does weight training knows that you can only push your joints so long before they'll fail if you're not rebuilding them. And nutrition is part of rebuilding your joints, just like resting them is, right?
I mean, yeah, that's a bit of a tricky kind of, again, there's a bit more nuance to the joints. So, I mean, if we simplify it down to the fact that, let's just say you've got this smooth layer of articular cartilage on the end of the bones. You know when you get a soup bone, right? And you've got that shiny white on the end of the bone. That is articular cartilage. It's super smooth, super hard. 2 sheets of that rubbing next to each other has less friction than 2 sheets of wet ice.
Wow.
So, good stuff. But the trouble is it can't regrow. So arthritis, osteoarthritis, is basically wearing that layer down. And we grade arthritis from grade 1 to 4 based on how much. If you wear, you know, up to a quarter of it, grade 1. Up to 3/4, grade 3. Up to all the way through, grade 4. So that's basically, so full fitness, grade 4. So that's how we grade osteoarthritis. Now, we cannot, even with all our, you know, our snake oil potions, and there's a bunch of guys out there doing PRP and stem cell injections and all this kind of crap, which has absolutely no scientific validity at the moment. And that's my profession of doctors who do that. Sports doctors will often do that. I think they're actually, you know, anyway. You cannot regenerate this cartilage, but we can make the cartilage that's there stronger. So if we zoomed in on it, what you would see is a cell we call a chondrocyte that was surrounded by a scaffolding, a protein matrix. And that extracellular matrix is what confers the structural properties of that tissue. So it's not the cell in the middle, it's not the chondrocyte, it's actually the protein structure that chondrocyte.
Wow.
So you might have grade 2 arthritis, you've worn a fair bit of it away, but you've still got some there. Now, the combination of regular exercise will stimulate the remaining cells to make a stronger protein structure, and providing your body with the nutrients it needs. It's a proteinaceous structure. If you don't have sufficient dietary protein, it's not going to be beneficial. And I'm not sure if you guys caught the paper published just a few days ago demonstrating that plant protein, I think they looked at soy and wheat protein, were deficient when compared to animal protein in terms of maintaining lean tissue.
Shocker.
Who would have thunk it? Now, so this idea is that your joints you can't regenerate a joint, you can't restore osteoarthritis, but quite often if we make that little bit of cartilage that's left more resilient, we can actually completely take away the pain. And I work with a surgeon, Jerron Scher, and probably about a third of his patients who would be booked in for surgery are able to cancel their surgery or do cancel their surgery after they go on a ketogenic diet, and they lose a bunch of weight, they get more protein in, their cartilage is working better. And there's also another big factor that's not the sole factor of why the cartilage gets better. This is actually a pretty cool story. Now, have you heard of matrix metalloproteinases?
No.
So this is.
I don't think I could even spell that. In fact, I know I can't spell it.
I was counting on that. I just made it up. I was testing it. So this is the only type of enzyme in the body that can break down collagen, can break down connective tissue. So we normally have a turnover of our connective tissue. We break a little bit down, we make a little bit more. When the balance is positive, we're gaining. When it's negative, we're losing. Now, these matrix metalloproteinases are actually made in the liver. And when you have fatty liver disease, your body makes more of them. So if you have fatty liver disease, you end up with more of these destructive enzymes in your circulation, which ends up just increasing the breakdown capacity of all the proteins in the body, the collagen type proteins, not all of them, including the ones in your articular cartilage. So if you fix a fatty liver, that often leads to an impressive reduction in pain in the knee because the extracellular matrix is stronger.
Wow.
And it's more resilient. And we know this because we routinely tell people lose 10% of your body weight and your pain will go down 30 to 50%. Now, if it was just a mechanical loading thing, that makes absolutely no sense. But if you understand that when you lose 10% of your body weight, the weight that you lose first is this hepatic fat that's contributing to this excessive secretion of matrix metalloproteinase, then it's very logical and it makes a lot of sense.
That's very interesting to me because I suffer from severe arthritis, theoretically or assumed to be psoriatic arthritis, but I also have compressed discs in my back, a torn shoulder, a GSW to the left hand, and on and on and on. And I just had to stop weightlifting. And then when I went back, now I can squat, say 250 kilos now, which is more than I could do before. So, and that's after like a 10-year break. And I do it completely pain-free, having, 5, 6, 7 years ago, my hands were so bad, I couldn't even turn a doorknob some days.
So you probably had an inflammatory component. So hand arthritis, there is a form of osteoarthritis called primary osteoarthritis, but if it's involved in the hands, it's often an inflammatory arthritis, which would then lead back onto an elimination diet. Taking away the triggers is probably going to be beneficial.
Sounds about right.
But I'll also say, if you're going to do weightlifting, check out my lectures. I've got lectures on FAI of the hip and low back pain. That will be particularly important. And like every area of medicine, this whole notion of what we do for low back pain is basically mired in bad science. And when you actually look, there's actually very good data about how to effectively treat low back pain, and it's routinely ignored. And it's really no different to dietary science. Medicine is fun.
Putting the fun back in medicine.
Agreed. It is fun whenever you start to feel better. It's just like, wow, and we love talking about this. We just love talking about the effects that meat and fat have on us.
And the bizarre thing is how hard it is to get medical people to listen.
Yep. My neurologist doesn't want to talk about it. My neurologist wants nothing to do with this. He just wants me to inject myself with the medicine because he's reading my MRIs and they say that I still have active MS. But all I've been eating is 50% animal meat, 50% animal fat for a year and a half.
So can I just ask, have you guys had any problems with gastrointestinal issues after carnivore?
No. At the beginning, transition.
At the beginning, yeah, during the transition time, for sure.
But not now.
I didn't have any. I went from like terrible heartburn all the time and stuff like that, and it just gradually went away, and I never had any issue. I never had keto flu. I never had any problems with eating all meat diet. I do kind of experiment with protein to fat ratios, trying to get the best performance and mood out of it, but that's it.
And I noticed that I did. Oh, go ahead.
I was doing this house when you went experimenting with protein to fat. This is for Tom. What did you find?
I tend to do a little bit better than somebody like Emily does with higher protein. but I'm literally twice her size, and I lift weights and she doesn't, right? And she actually tends to eat more calories than I do, but I probably have a lot more body fat to burn. So I'm not exactly sure where that lies, but we talk about that a lot because we notice that when people are leaning towards depression or anxiety, if they increase their fat, they often feel better. So maybe that's frequently a sign that they're not eating enough fat. But we talk about this a lot, and it's clearly not the same for everybody. But I'm probably a little bit more than 50% protein and a little bit less than 50% fat.
Okay, which would have you at a obvious. That's by weight, I imagine. So your caloric intake is going to be 2 to 1.
Yes. And
now, I see Emily just dropped off there, I noticed.
She probably got an important call. Yeah.
Oh, no,
she's there. She was there.
But I'm also a higher fat. I cannot operate without a higher fat, but I am an alternate day eater. So on my alternate days of fasting, as they call it, I do have fat during those times. About under 500 calories. Sometimes I go up to 800, but typically I keep it that way. And it's very comfortable.
Okay, and how do you consume your fat? Because I've had some people tell me that when they have a supplemental fat, like a block of lard or tallow or something, that they get a different experience than if they're actually cooking up fat trimmings.
That's right. So I buy a big ribeye roast. And then I'll, it's got that big block of fat. I actually don't like eating that with my ribeye, so I save that for those fasted days. And then I'll take a chunk of it either raw or warm it up and then eat that way. And that's been, and as you can tell, Emily actually freezes it. Emily, tell him your experience on how you're doing yours.
So I don't know if you can even see this.
Yeah, I can see that. That looks like what I've got in the fridge at the moment, actually.
So I go to the butcher and I just ask for beef fat trimmings, say the stuff that you throw away. And then I just cut it up into little bite-sized pieces and freeze it. And I eat it raw and salted. And I eat about three-fourths of a pound of fat a day. And about 1 pound of just beef a day.
Have you experimented with cooking it to see if there's a difference?
Yes, I feel sick. It makes me nauseous, like greasy.
So if you eat it uncooked, you feel much better?
No problem. I have no problems.
Wow.
I am the same way, actually. When I have it cooked, I feel a little queasy, so I can't handle as much. But when it's raw, I don't have any problems.
And I just pop it. Like I'll go, through the house and I'll just take a handful in the middle of the day and it's like my snack. And it's kind of like cheese. Like when you bite into it, it's really kind of dense and savory.
I eat about half of my meat and fat raw and half lightly cooked or seared.
Okay.
Yeah.
I have had a couple of patients who have actually had multiple parasitic infections. And so I suspect it depends on the source of your meat as well.
Yeah, I'm very particular about where my source is.
Mm-hmm. Well, it's interesting.
I did have
supermarket meat.
No.
Yeah. People don't think twice about eating, sushi raw all the time, which when I get it, I might eat a pound or 2 pounds of raw bluefin in a day if I get my hands on it. But then, like when it comes, I almost eat exclusively beef in most cases. So, and I'm fairly picky about where I get it. I get a consistent quality beef. So.
And I noticed that I did have more indigestion with whenever I was eating shrimp and when I was eating chicken. And as soon as I transitioned to mainly beef only, I haven't had any indigestion.
Yeah. Well, what I've actually, on the odd occasion, I do food antibody testings. We test for something called immunoglobulin G, which is not the classical food allergy, but it's a food sensitivity one. And we can actually compare the antibody responses against 200 different foods.
Wow.
And for occasionally some people will be, be it an animal-based food or not, some people still have sensitivities, and it's very interesting to see the how some people are just intolerant of specific foods.
I know I am.
Well, Emily actually eats raw. She doesn't cook any of her food.
Yeah. And that's not for any specific reason. It's just because I wanted to push the envelope of laziness. I was so grateful that I didn't have to go shopping for all this food. I was so easy to have a meal plan. And then I was like, what if I didn't have to cook it? Like,
you feel best that way, right?
And I do. I feel so good. And I've been eating raw since January.
Respect.
But
I have the occasional beef tartare, and sushi. I like my steaks dripping, but I'll always I like a bit of less healthy, but a bit of char on them.
Yeah.
They're just nice. Anyway, guys, I'm afraid I have to go. I've got another appointment.
Dr. Mason.
It was a
But
pleasure
this was-
talking to
Dr.
you.
Mason.
This was
Thank you very much.
a fun chat for me.
Yeah.
Fantastic. You're absolutely welcome back anytime.
Anytime. Anytime.
Much appreciated. Have a great rest of the day, guys.
You too.
Bye.
Thanks, Doc.
Bye.
Bye.
All right. I think he dropped off, right?
Yeah.
So
Do you
we'll
wanna
just
close it out?
Yeah, we'll close it out. I'd just like to thank everybody for watching. Did you guys have any closing comments?
That was awesome.
That was cool.
That was,
That was
really
so
cool.
Like,
cool.
subscribe. This is the
Yes.
one.
Like, subscribe. We're upping the content. That means you to up the likes, up the subscriptions, leave
Some
comments.
questions for the next time Dr. Paul Mason comes on.
Yes,
Yeah.
yes. That blew my mind, y'all. Like,
Yeah.
blew my mind.
Yeah, me too. I'm gonna be watching this over again real soon.
Yes.
And thanks for all the new. There has been some new subscribers. Thanks for the new subscribers, and thanks for the comments. Keep leaving us comments, folks.
And I was
whatever-
actually unsubscribed from the channel, which is funny because I'm literally on the channel, but unsubscribed from the channel.
yes.
I might be too.
I better
Check my
check.
subscription.
This is
I better
rampant.
check.
It's a good thing. You guys out there who, if you have channels you like, make sure you stay subscribed, because a lot of people are getting unsubscribed somehow. Nobody really knows what's going on, but it happens particularly to independent content providers like myself. So make sure you're staying subscribed to the people you want to see. And until then, eat some meat, feel better, and
Don't
Don't
fall down the carb
Down the
hole.
carb hole.
carb hole.